In this presentation, we will discuss high altitude illness. In part 1 of this presentation, we will cover background on high altitude. We will discuss how your body acclimatizes when it gets to high altitude, and I will present a case of acute mountain sickness. Physiological effects of high altitude as seen by your body at greater than 1,500 meters, around 5,000 feet. Your body experiences hyperbaric hypoxia. Although the percentage of oxygen in air doesn't change much with higher altitudes, it stays at 21%. The partial pressure of oxygen does. Increasing altitude results in decreasing inspired partial pressure of oxygen, or PiO2, the red line, arterial PaO2, green line, and arterial oxygen saturation, SaO2, the blue line. Note that the difference between PiO2 and PaO2 narrows at high altitude because of increased ventilation. Also note that SaO2 is well maintained while awake until over 3,000 meters, or around 10,000 feet. This slide demonstrates incidence of altitude illness in various groups. In the United States, almost 30 million people at risk of getting high altitude illness when visiting western states like Colorado or Utah, oftentimes for ski vacation. Mount Rainier climbers are also at a high risk, one study reporting 67% incidence of AMS, or acute mountain sickness. Kilimanjaro hikers have an incidence of 50 to 83% of acute mountain sickness. Other groups to consider are military personnel and pilgrims who travel to high altitude places. What happens to your body once you arrive to high altitude? This process is called acclimatization. Within minutes to hours, you developed increased respiratory rate. This is due to hypoxic ventilatory response, or HVR. This is an important response as breathing off carbon dioxide allows for more alveolar oxygenation. Carotid bodies sense decreased PaO2 and signal central respiratory center and medulla to increase respiratory rate. Further increase in respiratory rate is limited due to alkalosis. Within hours, your blood pressure and your heart rate also increase. Within 24 hours to a few days, pulmonary vasoconstriction develops. Within 24 to 48 hours to a couple of days, bicarbonate diuresis occurs. Bicarbonate diuresis is important as it accommodates for increased respiratory rate and the alkalosis it creates. It takes weeks for significant red blood cell production to occur and accommodate more oxygen. Genetics is another important factor in the acclimatization process. Some people acclimatize faster than others. Genetic research is underway to help us further understand altitude illness. In the following slides, I will present a case that I saw while working with Himalayan Rescue Association in one of their high-altitude clinics. After arriving to Kathmandu at 1,400 meters, we traveled to Manang at 3,500 meters over 7 days. Manang is located on the Annapurna circuit in the Nepali Himalayas. Annapurna trek takes about 21 days to complete by foot, and the highest elevation is 5,400 meters at Thorngla Pass. The clinic was located 2 days prior to getting to the pass at 3,500 meters. So let's see our first case. We have a 28-year-old female trekker who is complaining of headache, vomiting, and poor sleep. She's planning to ascend further to 4,100 meters tomorrow to the next town on the trek. When you see her oxygen level is 86% on room air, her heart rate is 110, her lungs are clear, and her neurological exam is normal. What do you advise to this patient? A. Take dexamethasone 8 milligrams now, then 4 milligrams every 8 hours until you're over the pass. B. Do not ascend further until your symptoms resolve. C. Descend immediately. D. Drink at least 4 liters of water to prevent acute mountain sickness. So what is acute mountain sickness, or AMS? The symptoms of acute mountain sickness are described as the symptoms of a hangover. One suffers from a headache, nausea, vomiting, lassitude, lack of appetite, lack of sleep. In research, Lake-Louise score is often used, and it classifies AMS further into mild, moderate, and severe. Risk factors for developing AMS include rapid ascent and genetics, or prior AMS. Some differential diagnosis for acute mountain sickness is dehydration, heat exhaustion, migraine, hangover, electrolyte abnormalities like hyponatremia. All of these can develop at high altitude. However, if your patient recently arrived to high altitude and has any of the risk factors for AMS, AMS should be your leading diagnosis. Let's talk a bit about AMS pathophysiology. As I mentioned before, failure to acclimatize leads to AMS. So someone who is genetically predisposed to have poorer hypoxic ventilatory response, or HVR, will take longer to acclimatize and is at risk of developing AMS. You also develop increased sympathetic drive, fluid retention, and eventually brain edema and severe AMS. This will transition to high altitude cerebral edema that we will discuss in part 2 of this presentation. So how do you prevent AMS? Slow ascent is essential. There are various recommendations on how fast you should be going up, but once you're above 3,000 meters, in general, it's suggested to not go up by more than 300 to 500 meters as your sleeping altitude per day, and have a rest day every 3 days. Acetazolamide or Diamox 125 milligrams twice a day can be used for prevention if you are planning to not be following the recommended ascent profile, or if you have one of the other risk factors for AMS. Dexamethasone is controversial but can be used in prevention of acute mountain sickness. Coca leaves and ginkgo also have some protective effects on development of acute mountain sickness. AMS treatment. Number 1 rule is to not ascend any further. If you have severe AMS, you should probably descend, as you are at a much higher risk of developing HACE, which is high altitude cerebral edema, a very dangerous complication of high altitude travel. The treatment dose of acetazolamide is 250 milligrams twice a day. Ibuprofen for headache, and dexamethasone can also be used to treat AMS, but its use is controversial, as it is also the rescue medication for people suffering from HACE. So in this case, you advise to your patient to not ascend any further until the symptoms resolve. So what happened to our patient? She was started on acetazolamide or Diamox 250 milligrams twice a day, or the treatment dose. She was also given ibuprofen and ondansetron for her headache and nausea. She ended up staying 1 extra day in Penang until her symptoms resolved and she felt better. She was able to continue her trek further to Thorong La Pass.